Rhexis runout is one of the most important and known complication in cataracts like these, where you can see fronds of liquefied cortex threatening to rip that anterior rhexis out. Hi, this is Dr. Semanchal Goel, and today I'll be sharing you this very interesting topic, that is Rhexis runout, and how your saner minds should always guide your decision making in situations like these. So right at the bat, I think this was the last case. I generally keep these patients as my last case of the day, and I did not know what I was going to face. And in cases like these where I see that the intralenticular pressure is high, my protocol says I must inject the patient with 300 cc's of mannitol IV. But in this case, I did not do it. I gave this patient 500 milligrams of acetazolamide because I think it causes minimal shrinkage of vitreous, leading to decrease in the intralenticular pressure. It serves as a safety net just for my psychological benefit. And I generally ask my OT assistant to keep a micro Rhexis and a micro forceps ready as well, just in case if I have a salvage situation. And yes, I have stained the capsule. I give ample time for the dye to stain, which ultimately decreases the elasticity of the entire capsule as well, making the procedure a little safer for me. And uh, I'll be using a combination of tearing and shearing forces. If you want to learn what tearing and shearing forces are, just Google it and you'll come to know. In the meantime, I'm going to post some videos on Capsulorhexis as well, so you better watch out for those videos. And I have dedicatedly filled the anterior chamber with a lot of visco to push the lens iris diaphragm back, and thereby giving a counter downward force. And yes, I started the Rhexis. I punctured the capsule, and from the beginning this capsule was sinister looking, and it tried to run out at 3 locations. In the starting 1 and 2. Yes, I was able to salvage it back using that shearing force, and I got overconfident. Yes, boom, the Rhexis has gone to the periphery in no time. I admit I was an overconfident surgeon at this point. I thought I would be able to complete the Rhexis, but it ran away. Just if you would like to see this in slow-mo, I have made the mistakes visible for you in slow-mo, what not to do. So generally speaking, 90% of these high intralenticular cases, I perform these with ease. I don't have any problems. But in some cases, yes, I too can get these tests of time where God tests your education, your practice, your experience. And just like that, it threatened to run away in this 6 o'clock position as well, but I was able to salvage it. And I tried my best to fold that capsule on itself and pull it. And I am pulling this margin in the center, and boom, in no time. I should have put more visco in the interior chamber at this point. But yes, the things are done, the damage is done, and it's now your job to switch on your damage control mode. And this video is specially for the surgeons who are in their initial learning days, and for experienced surgeons as well. This is a pleasant treat to watch. How am I going to give this patient a brilliant outcome? And I've just sped up this video because for me, the surest way to give this patient a visual outcome, a good visual outcome, is yes, it is SICS. I'm going to switch my SICS mode on because just for one single reason, I have completed cases like these where the Rhexis has gone out in 2 locations and even 3 locations. I have done phaco in them. I have successfully completed phaco and given these patients 6 by 6. But the only reason I attempted and completed this case with SICS is look at that nuclear density. You look at that nuclear density, it is upwards of grade 4. Just teeny tiny peak inside the cortical fibers will be able to tell you that the nucleus is very hard. And a Rhexis runout situation and you trying to chop that nucleus in the bag, you are inviting troubles for you. So you can see these brownish hues inside the hydrated cortical fibers, which tells you this nucleus is hard and you're not going to chop it safely inside the bag. Once you attempt vertical chopping and you try to separate those pieces, the anterior capsular rib can extend to the posterior capsule and it can land up in lens drop anytime during the phaco. I considered it the best to go ahead with the SICS. I have made an inverted frown incision. I have extended the tunnel to a decent diameter so that I don't struggle cracking the nucleus on the lip of the tunnel. And I want the whole nucleus en bloc. And I'll just prolapse the nucleus. See this big bulky nucleus? Once you'll be able to I'll be able to clear these cortical fibers, you'll be better able to appreciate the density of the nucleus. It's so hard. You were not going to complete this case. At this point, I was thanking myself for converting this case to SICS. The patient was on blood thinners, I came to know, and that's why the patient is bleeding a little more than the usual cases. And I have extended the tunnel even more. You can see the blood oozing in the anterior chamber, but yes, in no time the nucleus will be out. I have put more visco over the nucleus and under the nucleus, and I'll be using a plain Vectis, no irrigation, no funny stuff, no fancy brittle suture, and no cautery, and no nothing, because the time is running out. I need to complete this case. And boom. It's so satisfying. It's so satisfying that the patient who just threatened you with the Rhexis runout situation will now be having a good vision, all thanks to your versatility, your learnings, your experience that teaches you it is always better to switch on a safe technique rather than going out being a hero and taking it on your ego and telling yourself that yes, I am the superstar of this movie and I can do this case with a phaco in the bag and landing up in a lens drop and calling your retinal colleagues to take up this case, and then the patient having a vision of 6 by 12 all his life. So there's no shame in putting an incision and taking that bulky nucleus out, and look at that fundal glow. Just look at that small pupil and a crisp, brisk fundal glow. It's so beautiful. You're going to implant a monofocal IUL, and this is the obstruction to the photons that a patient suffers. Cataract of these grades are really common in India because the patients they hail from underprivileged backgrounds. They have a lot of problems going on in their lives. They don't seek immediate help for their ocular problems. But yes, we as ocular surgeons and physicians, we have taken an oath and we must do every bit to help help these patients out. For your information, I am operating this case under Ayushman Bharat scheme, which is sponsored by the Prime Minister of India. We did not charge this patient a single penny. And a little bit of kissing haptic situation going on, and I'm going to just push that IUL into the bag. I have not done irrigation aspiration consciously, because the pupil is small, and I'll do visco expression of most of the cortical fibers. The cortical fibers is absorb in these situations really well if you put the patient on low dose visolones and put the patient on IOP lowering and steroids, and the cortical fibers, if you're not even able to clean them up entirely, you can rest assured the patient is going to heal well in 30 days of time. And that's all. I am just completing the last teeny tiny bits of cortical aspiration by my eye and A. And you can see the blood in the 6 o'clock position. It's minimal. It's not going to pose any problem to the patient. It's because of the tunnel and the lack of cautery that I did not do. And I won't be using any sutures or final cauteries to reposit the conjunctiva, as I think the fibrin and thrombin of the patient's blood are enough for the wound to seal off entirely. Putting the air bubble in the AC to form the anterior chamber. And that's all from my side today. I think Rhexis runout situation is a common occurrence in all of our lives as surgeons, and saner minds should always prevail. Your smartness is not in your ego, but in the safety of the patient and the visual result the patient has. 1 month down the line, the patient is not going to ask you which technique did you use in my surgery, doctor. The patient is going to see through his eye and thank you. And that's all from my side. I hope you like my stuff. 60% of the viewers are not my subscribers. It is my humble request with folded hands to subscribe my channel. Thank you, and have a great day ahead.